the world you are in right now. I'm Dr. Heidi Buenaventura, Human Resources for Health Consultant of the Build Universal Healthcare Technical Assistance Support of the Asian Development Bank. On behalf of the ADB, I would like to welcome each and every one of you to the 16th Secure webinar series on planning and budgeting for HRH requirements at the primary level. As an overview, this webinar series aims to provide a platform for sharing experiences, challenges, and best practices in strengthening health systems and primary health care, highlighting key reforms from Indonesia, Thailand, Singapore, and the Philippines. The series hopes to foster cross-country learning and contribute insights for key decision makers and stakeholders for other Southeast Asian countries for their PHC reforms. For today's session, it will focus on Thailand's experience in planning and budgeting for their HRH requirements with focus at the primary care level. We hope that the session will be able to provide practical strategies for effective HRH planning and budgeting for primary care and present innovative approaches in recruitment, development, and retention of health professionals, including incentive schemes. For the flow of our afternoon's discussion and conversation, after this context setting, our main speaker will share on Thailand's HRH management and development experience, followed by reactions from our two invited panel experts. A Q&A and open forum will follow. So we are inviting you to please share your questions in the chat. Please introduce your name, organization, followed by your question. So with this, let me now proceed to our main session and let me introduce our speaker for this afternoon. Our speaker is currently the Deputy Director of the Division of Primary Healthcare Support, Ministry of Public Health, Thailand, and the Director of Khao Yoi Hospital, Phetchaburi Province. Also a family physician and lecturer of Ratchaburi Hospital, our presenter has been immersed in the field of family medicine and primary health care. Everyone, let's welcome Dr. Arawan Tawaiti Bongs. Dr. Arawan, the virtual room is yours. Thank you.
Thank you very much for your introduction. Now I would like to share my presentation here. Can everyone see the presentation? I guess so. So let's start it with the brief introduction on the planning and budgeting for the health resources that require in primary care. Today I would present as the partly for the national level and partly from the local level. And good afternoon, everyone, and distinguished participants from the Asian Development Bank and esteemed delegates. It is my honor to address you today as a guest speaker on the topic of human resource planning and with a focus on a lesson learned from our countries. Allow me to introduce myself briefly. I currently serve as the Deputy Director of the Division of Primary Care Support. And my responsibility encompasses supporting health workforce, building capacity, and strategizing for the future decentralization of primary care to the local government. And today I will share with you 4 decades of our experience in human resource for health planning and budgeting. This presentation will highlight the valuable lesson we have learned throughout this journey. Should you have any question during the presentation, please do not hesitate to raise your hand or utilize the chat function. Your engagement is both welcome and appreciated. Let's look at Thailand at a glance. Thailand's health profile as of 2024 presents a compelling narrative of progress and strategic healthcare management with a population of approximately 72 million, including 5 million non-Thai residents, GDP per capita of $7,800 per capita in 2023. Thailand achieved remarkable health outcome. Life expectancy has reached 77 years overall. and with, of course, favoring female more than males. And significant strides in maternal and child health are evident, with an under 5 mortality rate of 7.8 deaths per 1,000 live birth, and maternal mortality ratio of 37 deaths per 100,000 live birth. And we have almost 99% universal coverage of skilled birth attendance. The country commitment to healthcare is reflected in its total health expenditure of 300 US dollars per capita, constituting of 4% of GDP, with 70% derived from public sources. Notably, the implementation of achievement of universal coverage since 2002 has led to substantial improvement in financial protection. Out-of-pocket payment reduced from 40% to 8.67% of current health expenditure, and the catastrophic health expenditure affecting only less than 2% of the Thai household. These indicators collectively underscore Thailand's successful health system reform, positioning it as an exemplar among middle-income countries in balancing improved health outcome with enhanced financial protection. Through continued vigilance and adaptive strategies remain imperative to address emerging health challenge and sustain this positive trajectory. Let's look at Thailand healthcare system structure. The Thai health system evolution reflects a centralized public dominance model led by the Ministry of Public Health, which operates 70% of hospital beds nationwide. This structure, underpinned by the pro-poor ideology, significantly impacted by the 1997 Southeast Asian financial crisis. The ensuing political instability creates a window of opportunity for healthcare reform, culminating in the implementation of universal health coverage. This pivotal shift reshaped Thailand's approach to healthcare financing and access, demonstrating the system adaptability in response to economic challenges while maintaining a focus on equitable health outcomes. To ensure equitable access to care and efficient health service delivery, it is, of course, crucial to maintain a sufficient and sustainable health workforce. Since 2007, the WHO World Health Organization has included the management of health workforce as one of its building blocks for strengthening health system, as you can see here in this graph. And of course, the WHO, the evolution of Thai health system began not just in 2000, but we started since 1960 and was significantly influenced by the Alma-Ata Declaration in 1978, which aimed to strengthening primary health care. The Ministry of Public Health served as the main purchaser at that time and also the provider of health services. Initial effort focused on building primary care infrastructure, including health centers and health posts and district hospital. Additionally, various strategies were implemented to increase health workforce and maintain the capacity in rural area. We're focusing a lot in the rural area in 1960, 1970 until 1980s. During the 1960s, the country was still combating with communicable diseases such as malaria, dengue, polio, and tuberculosis, with primary healthcare workers playing a crucial role in these vertical programs. I wouldn't talk more on this evolution, but I will focus on the health workforce. And with the WHO report on the decade of health workforce strengthening published in 2015, present data indicating an increase in the number of health workforce in Southeast Asian countries, particularly Thailand. You can read this report from the link I share here. Since the initiation of the Sustainable Development Goal, there has been a significant commitment to strengthening the health workforce, highlighting its pivotal role for policymakers. This graph from that book, from that report, show that Thailand has a substantial number of health workers who support doctors and nurses. These include medical assistants, community health workers, traditional medicine practitioners, and paramedics. That also, although we have less doctors, nurses, dentists, and pharmacists than Korea or Maldives, but we have other primary healthcare workforce who help the main five professionals. There are three key strategies to address the shortage of health workforce, especially in the rural area. First of all, of course, increase the number, but how? That I will elaborate in the next slide and presentation. Secondly, enhancing the flexibility of the health workforce through measures such as task shifting, upskilling, reskilling, expanding roles, and leveraging with health technology, helping the health workforce with the new coming telehealth and telemedicine. Increase support for workers in practice. This is very crucial. If you want to sustain the health workforce in the disparity area, you have to increase the support for them. But how to increase the support, I will elaborate later. This presentation outlines the 4 decades of health workforce planning and budgeting. In the early 1960s, I mentioned already, we trained village health volunteers to assist the vertical programs in communicable control, health education, health promotion, and concurrently, we began offering scholarship to medical and nursing students from the rural area as part of the health workforce planning. And from the 1980s to 2000s, we expand medical and nursing school across the country, including projects to increase the number of rural doctors managed by the Ministry of Public Health. During the 1980s, we introduced a mandatory program requiring doctors, nurses, dentists, pharmacists to work in rural settings for 3 years before they can pursue specialized training. From the 2000s till present, efforts have focused on building the capacity of primary care workers since we already have Primary Care Act 2019, including the establishment of official family medicine residency training in primary care provision as well as primary care management, despite an ongoing shortage of family doctors. A multidisciplinary team established since the 1960s continue to support primary care delivery. Recently, the aftermath of COVID-19 pandemic, health technology has been utilized to provide primary care to marginalized patients who cannot come to the hospital, who doesn't have access or who live in remote area, and the vulnerable population, for example, elderly who doesn't have caregiver, they can use telehealth and telemedicine. Let's take a closer look at the unsung hero of Thailand, the village health volunteer. The village health volunteer in Thailand have played a crucial role in the nation's healthcare system since their initiation in 1960 as part of the primary healthcare strategy. That presents an impact expand nationwide in the 1980s, significantly contributing to public efforts. I see something from the chat. Okay, I will answer that later. I think I should finish the presentation first, but I will come back to the question. The significant contributing the village health volunteer have significant contributing to public health efforts and their tasks with a variety of responsibility, including health education and promotion, basic uh, basic health screening and monitoring, and assisting in disease prevention and control, for example, the COVID-19 pandemic. Additionally, they are the link between the community and the health facility. They are the link between community to health posts and health centers and also district hospital. The village health volunteer become indispensable to Thailand healthcare infrastructure, and they addressing both immediate health needs and long-term public health goals. How they are trained. The training and support by the public health officials, followed by ongoing capacity building and refresher course to ensure their skill remain up to date. And they also benefit from regular supervision from local health centers and district hospital. They also have the continuous development and effectiveness. The impact of the village health volunteer has been significant, leading to improved health access to basic health service in rural area and enhance community participation in health initiatives. Moreover, village health volunteer has proven to be crucial in health emergency, for example, COVID-19 response, demonstrating their vital role in the resilience of our health system. And however, there are challenges remain, including aging volunteer. Some of them work since 1970s, 1980s, so they are already aging and they have to adapt for the changing health needs from communicable disease to non-communicable diseases, and also additionally integrating village health volunteer with urban health initiative presents another layer of complexity that require ongoing attention and adaptation. These are from the report of the WHO. About our unsung hero, you can read from the link that I share here. Since the 1980s to 2000, Thailand has undertaken significant efforts to strengthen its healthcare system, beginning with a focus on increasing the number of health workers and establishing rural health centers. In the 1990s, the introduction of mandatory rural service of medical graduates and nurses, and also dentists and pharmacists during that time. And also they have to work in the rural setting for 3 years before they can pursue their specialized training. And also the expansion of medical and nursing school further bolster increasing the health workforce. And in 2000, the implementation of USC already accomplished, and alongside increased emphasis on primary health care through initiatives such as family medicine training. These efforts collectively aim to enhance accessibility, quality, and sustainability of healthcare system across Thailand. And from 2010 to 2000, till present, we are now focusing more on quality improvement and provision of specialized care alongside the integration of technology in healthcare delivery in the resource poor setting that they can consult online or with technology, telemedicine or telehealth. And the strategies that we use to address workforce shortage. Of course, everywhere has workforce shortage. Even in Thailand, we still have workforce shortage due to maldistribution of the main providers. The enhancement of training encompass a multifaceted approach, including the expansion of medical and nursing school capacity to accommodate more students, The establishment of new health science university in rural area to address workforce distribution disparity. The implementation of short-term training program to equip existing health workers with specialized skills. For example, we have short course training for doctors for at the and also we have an continuing education and professional development opportunity for ongoing skill refinement and knowledge enhancement. This strategy aims to cultivate a proficient and well-equipped health workforce capable of meeting the evolving demand of healthcare landscape, particularly in the underserved area, thereby ensuring delivery of high-quality healthcare. These are the projects that I mentioned, the collaborative project to increase medical doctors in the rural area, and also the nursing college and public health officer college that manage. These colleges are managed by the Ministry of Public Health. And those who graduated from this project has to stay in the rural setting for 3 years. Or we have another program called ODOT, One Doctor, One District. This group of recruited medical doctors, they have to spend at least 10 years in the rural context. But we have something that they can train along the time that they spend in the rural area. They can go for family medicine training. And another strategy is task shifting of healthcare involved, empowering nurses and community health workers to undertake responsibility typically have to carry out by doctors, but in some areas that they don't really have enough doctors, nurses and community health workers or village health volunteer helps solution of healthcare among different level of operations and treatment skill to enhance their capacity to provide comprehensive care at the grassroots level. Additionally, leveraging the expertise of pharmacists for basic health screening and the management of chronic disease can further expand access to essential health service and improve health outcome within the communities. By strategically relocating tasks and responsibility across various healthcare roles, task shifting holds the potential to enhance efficiency, increase healthcare access, and promote effective healthcare delivery, ultimately benefiting both healthcare providers and patients alike. Another strategy is the innovative strategy in healthcare delivery, being increasing to address challenge in healthcare access and delivery. The utilization of telemedicine has emerged as a powerful tool to bridge the gap between rural areas and specialist care, enabling remote population to access medical expertise and consultation without the need for traveling to the hospital or to the health center. Moreover, the implementation of financial incentives for health workers stationed in rural area serves to incentivize and retain skilled profession in underserved region. Therefore, this healthcare provision are bolstered where it is more needed. Collaboration with the private sector for training initiative and service delivery can bring additional resources and expertise to healthcare system, fostering innovation and efficiency in delivery of care. Furthermore, community engagement through the mobilization of health volunteers plays a vital role in promoting health awareness, preventive measure, and community-based care initiative. effectively empowering local community to take charge of their health and well-being or self-care. By embracing this innovation strategy, health system can enhance accessibility, quality, and sustainability of delivery of healthcare. And the last one is the long-term plan. In healthcare, it entails a strategic approach encompassing various key elements. First of all, workforce forecasting and need assessment approach. These one are fundamental components of this planning, enabling the healthcare system to anticipate future demand and allocate resources effectively to address workforce shortage, or some places have surpluses and how to reallocate the resources. Additionally, the regular review and adjustment of health professional education curricula are essential for ensuring that educational programs align with the evolving healthcare needs and technological advancements. Thereby, we equip graduates, not only doctors, but nurses and other health providers with the necessary skill and knowledge to meet current and future healthcare demand. Collaboration with international organizations for technical support and best practice play a crucial role for in fostering knowledge exchange, capacity building, and the adoption of evidence-based approach to healthcare delivery. By incorporating these elements into long-term planning strategies, healthcare system can enhance their resilience, adaptability, and sustainability in addressing complex healthcare challenges and promoting improved health outcome for the population. About incentive, of course, we cannot sustain the health workforce in the remote or in the disparity area. We need an incentive. It's play a crucial role in fostering, motivating, dedicated health workforce. These incentives include rural allowance, which offer additional payments to healthcare professionals working in remote or underserved area to mitigate the challenge associated with geographical isolation and limited resource. Hardship allowance is another incentive. Provide extra compensation to those working in demanding conditions or high-risk environment, acknowledging their sacrifice and difficulties they face delivering healthcare services, for example, in the deep south of Thailand that still have some political instability. Furthermore, reward tied to the achievement of specific health targets or in quality indicators or P4P, pay per performance, serve a motivational tool to encourage health workers to strive for excellence in patient care and outcomes. Ultimately, it enhances quality of care and healthcare delivery. Overtime payment is a form of additional compensation provided to healthcare professionals for working beyond their regular hours, a practice commonly observed in public hospitals where staff may require to handle increased patients' loads or emergencies. This financial incentive is also extended to those working in remote or isolating settings, as well as to specialists who may be called upon to provide expertise outside of their regular working hours. By offering extra payment for overtime work, healthcare institutions recognize and reward the dedication and commitment of their staff, ensuring the continued delivery of quality care and service to the patient in need. Not only monetary incentive, but of course, career development incentive are essential for attracting and retaining healthcare professionals in the underserved or in any areas. Fast track promotion program offer accelerated career progression opportunity for those serving in rural regions, recognizing their commitment to addressing healthcare disparity. Some of specialist training will be open since first year of their rural work, and many medical doctors who serve in the south or in the disparity region can pursue their specialized training earlier than their friends who work in the centralized or urban area. And they also have promotion faster than their peers. And also specialized training initiative provide access to advanced program and fellowship along with scholarship for further education, often requiring return. It's like an MOU between the Ministry of Public Health that these people who get the scholarship has to return to the service agreement to ensure for professional contribute their enhanced skill back in the community where they have to come back to serve. Research grants play a pivotal role in fostering innovation by funding research projects, particularly in priority health areas, for example, long-term care, palliative care, NCD, and enabling healthcare workers to advance knowledge and practices for improved patient care outcomes. These career development incentives collectively aim to enhance the skill set, motivation, and retention of the healthcare professional. And another one is the educational incentive. In the healthcare sector, where we play a vital role in addressing workforce shortage and improving access to care. Targeted admission program prioritize students from rural background by offering special admission quotas into medical and nursing school. The collaborative project to increase rural doctor that I showed before, and also the nursing school that recruit from the local context or the rural area, aiming to increase the representative of healthcare professionals from the region where they have shortage of workforce, and also loan forgiveness program providing financial relief by partially or fully forgiving educational loan for individuals who commit to serve in high need area, encouraging healthcare professionals to dedicate their skill and expertise to community facing healthcare disparity, which means they don't have to pay back, but they have to work in the community that have shortage of health workforce. These educational incentives work synergistically to attract and support a diverse and dedicated health workforce, and of course, ultimately enhancing healthcare access. And the last one, to support their work quality of time. It's very crucial for supporting healthcare profession in challenging work environment and promoting their well-being. Housing benefits such as free or subsidized accommodation, particularly in rural posting, help alleviate financial burdens and ensure comfortable living conditions for healthcare workers. Family support initiative, including educational assistance for the children of health workers serving in the rural area, contributing to the overall stability and morale of healthcare professionals by easing concern about their family well-being. Providing job opportunity for spouse in the government sectors, not only strengthening familial support network, but also enhance retention rates. For example, if the husband is a doctor and the nurse and the wife is a nurse, they can move to work in the same province. The opportunity will be for them easier and more faster than those who are not in the same family or household. And additionally, offering additional leave options such as extra vacation time or study leave for those in demand roles, enable healthcare professionals to maintain a healthy work-life balance, recharge, and pursue continuous professional development. Ultimately, it's foster job satisfaction and retention within the health workforce. But anyway, we still have challenges. The implementation of incentive program that I mentioned in healthcare sector come with its own set of challenges that need to be carefully navigated. One such challenge involves striking a balance between providing financial incentive to healthcare professionals, but at the same time managing budget constraints effectively to ensure the sustainability of incentive program over the long term. Because once you give them incentive, monetary incentive, you cannot reduce or cut back. We have to continue paying the same amount of money. And it is essential to monitor and evaluate the effectiveness of incentive scheme continuously to maintain their impact and relevance in attracting and retaining skilled health workers. Ensuring the equitable distribution of incentive across various health profession, because it's not only doctors but also nurses, dentists, pharmacists, public health officer, etc., and as well as the village health volunteer. Moreover, addressing potential unintended consequences such as internal brain drain from the public to private sector requires proactive measure to mitigate any adverse effect on the healthcare system overall functionality and service delivery. By acknowledging and addressing these challenges, healthcare organizations can optimize their incentive programs to better support and incentivize the workers while achieving broader system goals. So almost at the end of my presentation, we look ahead. Future direction in healthcare incentives involve ongoing evaluation and adjustment of incentive package to ensure their effectiveness and relevance in attracting and retaining healthcare professionals. Engaging health workers in the design and development of incentive program can enhance their alignment with workforce need and preference. Additionally, exploring non-financial incentive to complement monetary rewards can provide a holistic approach to incentivize and motivating healthcare staffs. It is essential to conduct rigorous evaluation to assess the impact of incentives on health outcomes and workforce distribution, enabling organizations to make informed decisions and optimize incentive strategies for sustained workforce engagement and improve healthcare delivery. Lastly, the key success factor. Critical factors in developing a strong health workforce include a robust health professional education system that guarantees the quality and relevance of training, and effective rural retention policies to address workforce distribution challenges, task shifting and skill mix innovation to enhance healthcare delivery efficiency, health workforce planning to forecast future needs and ensuring the right skill mix, and providing continued professional development opportunities for healthcare professionals to stay abreast of advancement and best practice. By prioritizing these factors, healthcare system can nurture a competent and motivated workforce to meet the changing healthcare needs of the community. So that's the end of my presentation, and thank you very much for your attention.
Thank you so much, Dr. Arawan, for that extensive, very rich, and insightful presentation. So there's so much activity in the chat already ever since you started your presentation, but I hope everyone will have the patience still to wait until our open plenary discussion and give time for our two panel experts to first react to Dr. Arawan's presentation. So we'll now proceed first to the reaction of our panelists. So our first expert, let me call on Dr. Pia Hanvoravongchai, who is the Secretary General of the National Health Foundation in Bangkok, Thailand. Dr. Pia has been active in health policy and system research and financing development in Thailand and regionally. He teaches health systems and health economics at Chulalongkorn University Faculty of Medicine. And before joining Chulalongkorn, Dr. Pia was a lecturer in health policy at the London School of Hygiene and Tropical Medicine and a research associate at Harvard University Global Equity Initiative. His recent research includes primary healthcare financing in Southeast Asia, and he is supporting the revision of Bangladesh health financing strategy. Dr. Pia formerly worked for the World Health Organization in Geneva and the Ministry of Health in Thailand. He was a member of Thailand's National Health Reform Commission, National Health Workforce Commission, and others. Dr. Pia received his MD from Mahidol University, his master's degree from the London School of Economics, and his doctoral degree from Harvard School of Public Health. So let's welcome Dr. Pia. Dr. Pia, the floor is yours.
Thank you so much, Dr. Heidi, and thank you for your introduction as well. Too long, I guess. But first of all, I would like to congratulate Dr. Arawan and thank Dr. Arawan for this very comprehensive, very insightful lessons from Thailand. She already started with the achievement that Thailand has done and how the effort to strengthen health system and primary healthcare paid off in terms of we saw good health achievement and low catastrophic spending and others. I totally agree with Dr. Orwan mentioned and also learn a lot from your presentation in terms of the details, pictures of how the system operate at the health service level, including the roles of how do you manage different type of health workers, how you incentivize them, and at the same time, you also very nicely, clearly show some of the main challenges that are coming. Coming from the health system view, I may be able to try to add or emphasize some points that I think are important from the system-based perspective. I think one first point is the underlying context of Thai health system that allow this to happen. I would say we are very much equity-oriented health system from the start. Thailand has very, what you call, public-dominated health service. About 70-80% of providers are in the public sector, financing, or 85% public financing. So it's in a way allow the system to be easier to prioritize equity in addition to efficiency and not leave it to the market to handle the issues. Investment in health system development, health service planning, health workforce development, all has strong equity intention when they started. And I think even nowadays when they implemented, there sometimes were tensions, no, normally between whether you want to invest more in primary health care or you try to build more hospitals in the big cities and others. Both are important, but sometimes you need to prioritize and balance so that it wouldn't be dominantly going to only one side, you know. And I think Thailand did pretty well in terms of the decisions of the government, in terms of health workforce, decision of positions of staff to be employed in the healthcare facilities, also based on service plan, which take into account shortage or overloads of work. So there's a team almost in every service area that they look into this kind of a network of providers and see how much or how many positions need to be considered in terms of allocation of position and others, and those also the expansion of health professional education training school. Dr. Orwan already mentioned, try to expand to smaller provinces in order for local recruitment of people in the area who will more likely to maintain or stay in those areas after they graduate. There are some other policies Dr. Orwan very nicely mentioned already. I think that's one first point I would like to raise, equity-oriented health system. The second point, Dr. Orwan also mentioned a lot, is the strong coordination, planning and work together at the national level, but also at the team level, team approach and others. The coordination across sector at the national level happen health workforce is not just about Ministry of Health. Basically, you need to deal with a Ministry of Education, you need to deal with health professional councils, you need to deal with many other sectors. In Thailand, there has been a platform under the National Health Assembly, which is a civil how do I describe it? More like a ways for people to shape policy through this National Health Assembly. They have a Human Resource for Health Coordination Committee that bring in different stakeholders from health professional education schools, health professional councils, Ministry of Public Health, employers, and others to come to discuss and support the key aspects of planning and also the share information and also address some of issues. Even though it's a more loose a policy development body, it's still helpful in terms of getting people together, getting them to share information, getting them to think about what to act together. At the health services level, I think we saw very clear from Dr. Oran's presentation about how the work as shared, both in terms of between health profession and non-professional, village health volunteers. They are the main, what do you call, important part of our health system. We have more than 1 million village health volunteers, so one every 50 to 60 people. So that's a big force. They don't work full time, only few days. Dr. Aran can elaborate more on that, but they important in terms of linking professional and non-professional together. Even among professional, no, in health service, we already heard hospital, health centers, pharmacies, and others. So there's some kind of trying to mobilize and coordinate between these different sectors to bring about the more effective, more efficient system. At the same time, trying to improve access to care, improve equity, and this come to my third point that's important is the active governance, active role of the system governance, trying to look into improving health system performance, primary healthcare performance, and Dr. Orwan is in the Department of Primary Healthcare Support, which very actively trying to do it with mandate from even the law that try to strengthen primary healthcare. In the financing sector, Thailand benefit from strong active financial management. When we had the big major reform in 2002 for improving universal health coverage, expansion of coverage to almost 100% of the population, the major issue is not just coverage expansion, it's about financial reform from previously supply side financing, line item budget into demand side financing, capitation based, and now evolved into more sophisticated financing mechanism. This active financial management is very important, and that also influence human resource for health financing, because even though we have government posts, but the funding will need to take into account the budget for those areas or the people that they cover, the service they provide, and it will be kind of managed in such a way that the area with more people will affect the amount that you get to support your staff in a way, and then it allows some flexibility for hospital, because in Thailand the hospital has some level of financial autonomy. That's another important aspect. So they have Ngan Bamrung, some add-on funding that the hospital can decide themselves. They can hire temporary staff to help with some work, or they can use the money to do something according to the regulations, but they have more flexibility, more opportunity, so they can manage and do in a more flexible manner. But yeah, like Dr. Orawan also mentioned, these are some of the system factors I can think of, but there are also challenges. I would also add more challenges in addition to decentralization of primary healthcare that we hope will bring in more responsiveness of the system, but will it affect the integrated care or coordination? That will be something to see. or the bigger challenges at the system level, no? Aging of the Thai society, NCDs, climate change impact, and all others, which probably will make the issue that Dr. Aron mentioned, the financial resources required for the system will be even more difficult. So I think that's probably my three main points. And thank you so much, Dr. Arawan, and thank you, IDB, for opportunity to also share here. Thank you.
Thank you, Dr. Pia. That was beautiful, especially on the emphasis of how strong values and ideology influence governance. So thank you, Dr. Pia. I'll now proceed to our next reactor. So our next reactor is a very familiar face. So he's Dr. Eduardo Banzon, currently ADB Director, Health Practice Team, Human and Social Development Sectors Office, sectors group who champions universal health coverage and has long provided technical support to countries in Asia and the Pacific. He was also the former president and CEO of the Philippine Health Insurance Corporation, World Health Organization Regional Advisor for Health Financing for the Eastern Mediterranean region, and WHO Health Economist in Bangladesh, and World Bank Senior Health Specialist for the East Asia and Pacific region. So, Sir Dodo, go ahead, please.
Thanks. Thanks, Heidi. Sorry. And first of all, thank you, Dr. Aron. Really wonderful presentation on how Thailand is addressing health human resource concerns, and for Pia for very insightful feedback and additional points on how Thailand is doing it. Would like to start my reaction by going back to what the slide, I think the third or fourth slide that was shown by Dr. Arawan, where he basically said there's no health services without health workers. In a sense, if you want to expand it, there's no UHC without health workers. And so I think sometimes when countries talk about UHC, it gets talked about in from a policy level discussion, or sometimes from a financing perspective that we sometimes forget. At the end of the day, it's the health worker that will provide the service. And I think this is a secret that Thailand, when people looks at Thailand as a great model, and the financing reforms brought by the UC is also, of course, another great practice. And a lot of other things that they're doing in Thailand. It is the fact that they took care of health workers and did a step by step, and really how the story evolved from the 1970s all the way to what is right now, moving forward, solving problems and taking on the next one, because it will not be solved overnight. It's actually such a great story on how Thailand is doing it. But nonetheless, I think as we listen to the presentation, one of the things we know, Asia now is adopting UHC. Every country that we're working on, where ADB is engaged with, is pushing for universal healthcare. So Philippines have a UHC law. Indonesia is doing a health transformation agenda. And Nepal is also doing a national health insurance. So every country that we're working on. And so the challenge now is at this point is that as we listen to Dr. Arawan and Thailand, as we reflect on how Thailand has done its job, what can you do rapidly? You wish that, you hope, we understand that it takes time, and which Thailand has. But Thailand, in a sense, also provides everybody a roadmap. It's in a sense a map that they can use, they could learn from, and hopefully accelerate some of the things that were done in Thailand, that took time in Thailand, and hopefully implemented in countries in Asia and the Pacific, and rapidly do it. So one of the things they did is really they build production. Okay, so they recognize that you could not just wait for the health workers to come. You need to build. You need to produce them. You need to, as much as possible, try to bring the production capacity, so the medical schools and the university and the teaching hospitals, as close as possible to where the people from. So the Philippines actually learning that lesson. When I took up medicine, we all have to go to the big cities. I'm from the province. I have to go to Manila to study. And I think it's a similar story with a lot of Filipino doctors of my generation, or even the younger generation. Now, the Philippines is actually doing a move of building medical schools, a lot of state universities, and the state universities are actually in the more remote, smaller provinces. So Palawan, that never had a medical school, is having one. Samar, and so on. So I think the Philippines is trying to do this rapidly. They're combining this with scholarship, but they also, I think, they need to have a concerted effort to make these medical schools and universities improve it as much as possible, invest. And I think investing in HRH, in health, human resource, health workforce is important. So they should scale up the investment that they have on these medical schools, and hopefully even have university hospitals or in the state universities where these medical schools are being built. And this can have hopefully compress a lot of the reforms that was built in Thailand. And then, of course, adopt things like the CPRD or the comprehensive program for rural doctors. And they can combine that. And hopefully this can, in the next 5 to 4 years, or probably the next 10 years, there's a regular supply of doctors that are being produced by these medical schools. I think as proven by Thailand, they tend to stay in where they study. People from Palawan or Samar will be most likely, or even in Tawi-Tawi, if you build a medical school there, will be most likely to stay in the area where they train. The second thing that lesson that Thailand showed is, if you look at the slide that they showed, the one from Shado's slide, the number of village health workers in Thailand is really huge, and they're taking care of them. And so we're still seeing the same similar reforms happening in a lot of countries. In Indonesia, they're investing in the Posyandu cadres. Of course, India has been doing that with the ASHAs, but I think there's a lot of lessons, a lot of sharing that needs to be done. The Philippines, we have the barangay health workers. So as the village health worker, the community health workers has always been around. But Thailand is doing a better job. And I think this conversation between how Thailand is doing it, admittedly, it's not just, and what Pia said, it's not just Ministry of Health, it's not just Department of Health, it involves a lot of other ministry. So I think a purposive focus on maximizing the barangay health workers in the Philippines, maximizing the Posyandu in Indonesia, which is an ongoing process, maximizing the ASHAs in India, should be something that need to be looked into as well. Another point that they put, of course, is sort of really a challenge that everybody's trying to do, the retention policies. Okay, you produce the doctors, you produce the health workers. How can you make them stay? So the tools that was presented by Dr. Arwan, were quite common to everyone. You required them to stay in 2, 3 years or 5 years in rural areas. They even have 10 years. I think more of that happening would be good. But what's more important is the way they're able to have this the way the payment scheme is actually changed. So it's quite interesting how they're able to do this, probably to explore, because of the uniqueness of the health sector, how this can actually be applied. I think the challenge has always been the moment you try to push for this type of policies, then the other sectors would also say, then of course teachers who stay in rural areas should also be paid differently. The bonuses will also pay differently. But to what extent was Thailand able to do this so that it's really focused on health workers and in a sense, sort of they treated specially, more unique, and so they're able to get their attention. Another thing that needs to be done, I think this already been proven in a lot of developed countries. Thailand is doing this a lot, task shifting. Now, we have to acknowledge the power of the medical profession is strong in a lot of countries. It's not just in your respective countries. And we know that doctors would sometimes push back, but at the end of the day, having a conversation that task shifting should be part of policy. Philippines have a lot of nurses, and I think probably a lot of wasted resources because the nurses are not even allowed to become municipal health officers. Thailand has a great scheme. They have a public health officers training school. But if you can only train doctors and not the other health workers, it's going to be a waste because you're not able to maximize a lot of the resources that you have in the system. So similarly, a whole story on task shifting in the region should be looked into, and in a sense, how we could try to see how this could be an experience that would share, how the policy bottlenecks, how the resistance was basically addressed. I think a final point, and what Pia, and again, I want to reiterate what Pia said. Health human resource, retaining, investing in health human resources, keeping your health workers so they provide health services for your UHC efforts entails more than Ministry of Health. So that's a very valid point, because when you produce, when you have your medical schools, you need higher education, whatever called ministries you have there. When you do your rural attention, usually that involves local governments or Ministry of Villages or Ministry of Rural Development or whatever it's called in this particular countries. Retention policies would need a lot of finance and budget ministries and planning ministry allowing, for example, the exceptional treatment of the medical doctors. Task shifting would entail really legislation because the resistance would be quite strong. But at the end, it's the Ministry of Health who's on top of that. The Ministry of Health in Thailand, as the way I understand it, and Dr. Arwan and the way I think Pia was also saying, and what I'm aware of, basically takes care of the whole health human resource system in general. They don't just look at it as if it's the staff of the Ministry of Health. They make sure that they're on top of everything from the village health workers in Thailand all the way to even doctors in the private sector. So I think this is going to be a key part of the reforms. The Ministry of Health has to step up and basically really oversee the whole health human resource system. Because at the end of the day, if they won't do it, then nobody else would. So I think I'll stop there. Thanks, Heidi. And again, thank you, Dr. Arawan. And of course, hello again to my friend Pia.
Thank you, Dr. Dodo. I think those insights can already serve as policy recommendations moving forward, sir. Yeah. So thank you for our panel experts, reactors. So let's maximize the remaining time for us to address the questions and also clarifications in the chat box and also in our Q&A section. So I think beforehand, Dr. Arawan has already answered some questions. I took the liberty of trying to categorize the question. So I think one of the many questions here involve financing. So the question maybe is about in terms of public financing in the workforce demands or in the incentives, how is the government able to carry the financing costs of all the initiatives and the strategies? And I think many of the questions here are also about the incentive scheme. So how is the financing also worked about there, and also the question on the private sector involvement. So I think Dr. Arawan or Dr. Pia can answer. Thank you.
Yes, thank you for the very good, nice question and very useful question for us too. For the financial support, the Ministry of Public Health has got the budget from the actually it's a tax revenue to reimburse in both health workforce and reimburse in the health system. And we focus not only primary health care, but also tertiary and secondary and tertiary health. But we try to emphasize more in the primary health care, because if we can prevent and promote the health of our population, and so that they don't have to get to the hospital or get sick, or we can screen before they get sick, that will be more cost effective to the system. But the incentive of doctors or nurses and other health profession, including village health volunteer. In the beginning, in 1960, the village health volunteer didn't get any reimbursement, but nowadays they already get a small amount, not like much, but a small amount of money for reimbursement. But mostly they are here, they are like volunteering. They didn't really mind about the money or the incentive in financial support. But I see some of the question asking about the opportunity for the village volunteer to upskill or maybe update the profession. I would like to say here that mostly the volunteer are people who work in the village, and they are most likely they are the older generation, not the young people. So for them to study or to continue professional development to become nurses or to become public health officer may not be their main interest, but their main interest is to collaborate with the health center or the health system and with the hospital as like a link, as someone who help the people in their community, but not like going to be training to be a health profession. And they prefer to work in the informal setting. If they are in the system, they're gonna be formal workers, and now there are many rules, and it's not flexible for them to work. So I assume from my experience that these people, they would love to be a volunteer and informal workers. They don't want to be like a health professional, but for their children, maybe for many of the village health volunteer workers, they would prefer their children to become nurses or doctors. And that we have the channel for them. They can be a recruit to study in the collaborative project of increasing rural doctor. And I'm
Thank you,
sure
Dr.
Dr. Pia can
Dr. Pia,
can
please.
I think Dr. Arwan is better, clearer on the front line. Maybe I'll add a bigger picture. I think there's a lot of question about incentives, but I would say that in Thailand, incentives are not just financial incentives. I think we rely on both financial and non-financial. Some of them are related to how you organize system and services, but financial also play some role. I think you need to make sure they have enough to survive and to work there. And but it's not the driving factor for people to work in rural area or in primary healthcare. Of course not. There are other reasons that they want to do it, or other reasons that keep them there. But definitely the system from the past trying to improve both one way through the employment, like Dr. Rowan mentioned, additional payment for rural area, for remote areas, and how do you stay long in the hospitals or other, you get some extra or something like that. Those are some incentive built into the position, but there are also incentive trying to build in on the performance or outcome base. Those are of what do I feel? Still ongoing and trying to learn from it, whether how much they are. I would see it more within the same organization to influence their relationship, the management of that, more than the incentive to stay, because the amount actually not that much for the performance management, very, very small actually. So that part is like a tiny add-on, like having a dessert, not the main dish, for them. I think I'll stop here first, because let's see if there are other questions.
Yeah, I think in terms of the financing question, maybe we can answer the question on the private sector involvement, and maybe Dr. Dodo can also share his thoughts on this.
Yes. For the private sector involvement, now we have something called innovative system that allow the private sector to become primary care unit. We allow private clinic, private physiotherapists, private nurses to be part of the primary care provider, someone who are not working in the public system. It's just started with the UC Anywhere. I'm sure many of you heard about that. We have the new policy around a year and a half of anywhere and visit primary care setting anywhere in Thailand. Actually, it's just to expand access to care for patients. And that we also have shortage of doctors in the public sector. We also have shortage of nurses in the public sector, and the innovative private sector involvement helps increase access to care. But at the same time, there are challenges coming with this kind of innovative clinics because it's not capitation. The National Health Security Office pay by fee for service. So it could become overutilized. Some of patients may be overutilized, going to the private clinic, going to the private nurse practitioner clinic, and then still come back to the public hospital. So we have to be very careful with monitoring and evaluation of the public-private partnership. But to me, I think it's a good channel and it's benefit the population, overall population. But the thing is the monitoring and evaluation that should be very careful, and how much we pay, because the budget is from tax. If the economic of scale in Thailand is not growing, the budget will still the same. And how we can reallocate or divide it among public and private sector. That would be my.
Thank you, Dr. Arawan. Any other thoughts before we proceed to our last question, live question?
Maybe I'll add a little bit. When Dr. Arawan answered, that reminds me what I mentioned earlier, very much for non-big urban city context, because that's also a challenge that we have. The system in the past wouldn't be workable with the primary healthcare in the urban area, like in Bangkok or in big cities. So that's why the universal health coverage scheme, the National Health Security Office designed with their area-based financing mechanism to have different modalities of payment. And like Dr. Oran said, case-based payment was used as a way to engage private sector, because you're not just about capitation. And especially for health promotion prevention services, you pay by the number of service you deliver, and that's a way to engage. But there are also challenges with how you measure, how you call in others, and the system is evolving. Yeah, but urban city is a bit more problematic. Yeah, urban big cities. Yeah.
Yeah. Thank you, Dr. Pia. All right. Dr. Dodo, would you like to share your thoughts, or we can proceed to another question?
We can proceed to the next question. I
Okay.
think Dr. Arawan, yes, ready.
Yeah. So another question is regarding the task shifting strategy. So maybe you can share in terms of what specific tasks are being shifted to community volunteers or to nurses and primary care workers, to what is ethically or legally allowed. So maybe you can share also on that.
You mean the
What particular task, probably one question here is what particular task of doctors are able to be shifted to community volunteers or nurse or primary care workers?
Okay. For the task that we shift to the nurses is like they have to train for 4 months to be able to take the role of doctors to provide care for common diseases. For example, flu, common cold. They will have this practice guideline that the nurses can perform instead of doctors in the remote rural in the remote area or at the health center level where patients cannot come or access to the hospital. The nurse can give vaccination. They can do wound dressing. This is just example that they can do. And some of them who train as an emergency nurse can do stitching, and even some of them can do if you have a fracture of bone but not displaced fracture, they can do the casting, and but under supervision of doctors. They have to consult the doctors, maybe on call or maybe on telemedicine. They can show the patients to the doctor and ask for permission if they want to do the casting, the non-displaced fracture. And for community health workers, maybe not this type of health provision, but they more likely to do the screening, to help doctors screen for hypertension. They will be trained to be able to measure blood pressure. They are trained to be able to do the dextrose strip to test for blood sugar, and they will be trained to be able to give health education to the community, to their village fellows. And some of the nurses practitioners will help doctors do the home visit and helping with the palliative care patient at home. Now we have the nurse who trained to do home ward. The patient may not be able to admit to the hospital, but we have something called home ward that the nurse will visit the patient at home, and the hospital will allow them to give provide care for this group of patients or the long-term care patient. And not only the nurse, but the physiotherapist, they will help the doctors and nurse to do rehabilitation for cardiovascular patients who have stroke or who have spinal cord injury, and help them. They don't have to come to see the rehabilitation doctor. They can go to the physiotherapist and have treatment. That's something that we do as a task shifting.
All right, thank you, Dr. Arawan. I think the audience is very much interested on that innovation, and I think other countries are also exploring that possibility in terms of like distributing the work across different types in the workforce. So I think we will be able to accommodate just one more question because unfortunately we
I
are
see
also
one
under
question
time pressure.
asking
Yeah,
about why. Sorry.
go ahead, Dr. Arawan. I'll give you the liberty to choose the last question.
I see one question asking why we emphasize on family medicine rather than
Yeah.
internal medicine and pediatrician. Actually, we emphasizing in every specialist, but I'm talking about family doctor because they're gonna be the gatekeeper, what we call gatekeeper, and also the manager of primary health care. So the number of trained family doctor in Thailand still shortage of them. Only less than 2,000 family doctors who should be able to take care of the 72 millions of population. And we would like to be able to take care of them before they get sick. So that's why the Ministry of Public Health and the National Health Security Office and everyone emphasizing on increasing number of family doctors. to be able to work in the close to the patient at the proximity. And in some countries, they also meaning of family doctors also meaning similar to GP, general practitioner. Some country also include internal medicine. Some country also include pediatrician in the team of family, in the team of primary care. So it's just that Thailand using the term family medicine. But internal medicine doctors or pediatrician also work with us too.
All right. Thank you. Thank you for that, Dr. Arawan. So, unfortunately, everyone, we have to cut our plenary discussion, but I hope that Dr. Arawan, Dr. Pia, Dr. Dodo will also take time to answer the remaining questions offline. And for those asking for the materials, we sent the link where you can access the recording and also the presentation materials. So, I think just to synthesize what has happened this afternoon, we were presented with a very extensive and very rich experience of Thailand in terms of their HRH management and development. And we can definitely see how strong governance and strong political will with foundations of strong values are able to really deliver services to their people. I think we were presented with both innovative and also strategic approaches in terms of HRH development. And I hope that we can continue the conversations moving forward on how different countries can learn from each other on how they can improve and also be able to provide holistic support to their workforce. So for the closing of our session, I'd now like to call on Dr. Alexo Esperato, our Senior Health Specialist at the Asian Development Bank, Southeast Asia and Pacific region. So Dr. Alexo previously worked in health systems in Latin America, the Middle East, and India with the Gates Foundation, World Bank, and World Health Organization. He obtained his PhD in health services at Hopkins University after being trained in economics and public policy. And he also authored several health system studies, including a Lancet report on primary healthcare. So Dr. Alexo, please.
Okay, thank you. Thank you, Dr. Heidi. ADB recognizes the importance of a strong health workforce in attaining, well, first, primary care and particularly universal health coverage. So we hope that this webinar has contributed to the ongoing discourses on how HRH, how human resources can be used to close the demand gaps. I would like to thank firstly our speakers, Dr. Orawan, Dr. Pia, and Dr. Anton. For sharing their time and their wisdom with us today, as well as the participants for joining us. It is through webinars like this that countries are able to share their best practices and learn from one another. I would also like to take this opportunity to mention two webinars that we'll be organizing in September. The first one will focus on non-communicable diseases and mental health, and the second one will focus on the Japanese experience on primary care, particularly how the local level is monitoring performance and how health financing is being tracked at the local level. See you in the next webinars and have a very pleasant afternoon. Thank you. Thanks for joining.
Thank you, Dr. Alexo. And again, thank you, everyone. So we hope to see you in our next webinar series. Thank you again for our dear guests and reactors. And thank you, everyone, for the time. Have a great week ahead.
Thank you. Bye.